examination of higher function, and very frequently in your ward during clinical examination you need to do examination of higher function. Okay. So, by now I guess you have a little bit idea on how to examine a patient, right, how to examine a patient. So, first whenever a patient is coming to your clinic, your first job is to take the history from the patient, right, take history from the patient. Say for example, any patient complaining of respiratory distress, श्वासकष्ट, ठीक है, respiratory distress. Now, with this respiratory distress you will take history, ठीक है, कब से है, सीजनल वेरिएशन है कि नहीं, ठीक है, किस टाइम ज़्यादा होता है, मॉर्निंग में, इवनिंग में, वेदर देयर इज एनी हिस्ट्री ऑफ स्मोकिंग और नॉट, ठीक है, और डस्ट एक्सपोजर में बढ़ता है कि नहीं, ठीक है, सो दैट यू कैन गेट क्लूज टू आइडेंटिफाई द एटियोलॉजी ऑफ द डिजीज, राइट. सो दिस इज कॉल्ड टेकिंग हिस्ट्री. फैमिली में और किसी का है कि नहीं, सो दीज आर ऑल हिस्ट्री टेकिंग, राइट. ओके, हिस्ट्री टेकिंग शुड बी इलैबोरेट. ओके, now after history taking, what you need to do is the general physical examination. Okay, general examination, general. So the patient is having respiratory distress, that doesn't mean you will only examine lungs. Okay, so it is general examination, you will examine top to toe, right. Okay, so under general physical examination or GPE you have few points like anemia, you will check for anemia, you will check for cyanosis, you will check for jaundice, edema, clubbing, neck vein, neck glands, and few vital parameters like pulse, blood pressure, temperature and oxygen saturation. Okay. So, whatever be your patient is complaining of respiratory distress, your patient is complaining of pain abdomen, your patient is complaining of chest pain, your patient is complaining of back pain, your patient is complaining of loose body, whatever, you need to do all the things, taking history and general physical examination for all, any patient. Okay, history taking and general physical examination is for all. Okay, now first history taking, second general physical examination, and third you should remember all the points under general physical examination: anemia, cyanosis, jaundice, clubbing, edema, neck vein, neck gland. Then under vital parameters you have pulse, blood pressure, oxygen saturation, body temperature, right. एकदम याद होना चाहिए, right. Okay, now after general physical examination you have systemic examination. Okay, so now under systemic examination there are lots of system. You have respiratory system, you have cardiovascular system, you have locomotor system, you have lymphoreticular system, you have nervous system. So there are many systems. So which system is to examine? So in our example, as the patient was complaining of respiratory distress, so you will examine patient's respiratory system and also cardiovascular system, because respiratory distress or শ্বাসকষ্ট এমন একটা symptom that can arise from the problem in the respiratory system as well as from the problem of cardiovascular system. Okay, and one patient is complaining of tingling and numbness sensation in the lower limbs. Okay, so this is a neurological system, neurological symptoms. So you will examine nervous system, patient's nervous system. Getting my point? Okay, so history taking and general physical examination is for all. Okay, and systemic examination you need to decide which system is to examine, right. Patient is complaining of chest pain, examine cardiovascular system, right. Okay, but not nervous system. A patient is complaining of chest pain, do you wish to examine his or her nervous system? No. Okay, so the sequence is history taking, general physical examination, systemic examination. History taking and general physical examination is for all, and systemic examination you decide which system to examine depending on the symptomatology of the patient. Okay, according to symptom of the patient you decide which system is to examine, and there may be multiple systems. For a single patient is complaining of respiratory distress, you examine both respiratory system and cardiovascular system, because you know that respiratory distress may arise from problem in the respiratory system primarily, and it may also arise from the disturbance in the cardiovascular system, correct. The patient is complaining of headache, you examine the nervous system as well. Okay, so systemic examination you decide. Patient is complaining of pain abdomen, you examine the gastrointestinal system, okay. Okay, so in this way examination runs. Okay, And after systemic examination, after doing systemic examination, you perform history taking, you perform general physical examination, and you perform systemic examination. Okay. Then you come to some provisional diagnosis. This patient is having bronchial asthma. Okay. It seems it is your provisional diagnosis. This patient is having bronchial asthma. Okay. Now you will advise the patient for investigations. You can perform a chest X-ray, you can perform some allergy testing, you can perform some spirometry or lung function test, and you can come to the final conclusion that the patient is having bronchial asthma. Okay. And maybe your provisional diagnosis are multiple. Okay. History taking, general physical examination, systemic examination. So ये तीन चीजें आप कर लिए, तो आपके पास अभी provisional diagnosis है. Maybe 4 or 5 diagnoses is coming into your mind. You are not coming to a specific कि this is a case of bronchial asthma. So maybe 4 or 5 diagnoses playing into your mind. Maybe it is a bronchial asthma, it is an emphysema, it is a case of bronchitis, it is a case of pneumonia, it is a case of fibrosis. So everything may happen. So these 4 or 5 diagnoses playing into your mind. Now you apply investigations and confirm diagnosis. Okay. So if it is possible that from history taking, say for example from history taking you get one point that the patient is allergic. Whenever there is dust exposure, the patient is having respiratory distress. Okay. You get this point, and in history the patient is not having any history of smoking. Okay. But whenever there is exposure to dust, and particularly during summer winter junction, the patient is having respiratory distress, and there is family history also. So this point you know from the history. So it is more in favor of bronchial asthma. Okay. It is more in favor of bronchial asthma. Now you come to general physical examination. You are doing anemia, cyanosis, jaundice, clubbing, everything. Okay, for the patient, and you come to systemic examination. You listen some. You put the stethoscope over the patient chest wall. You listen some wheezing sounds. Right. So it is more in favor of bronchial asthma. Okay. It may be COPD as well, but it is more in favor of bronchial asthma. Now you do investigations, you do pulmonary function test, you do chest X-ray, you do allergy testing, and the final diagnosis is bronchial asthma. So this is your satisfaction. What was your clinical diagnosis? It is confirmed by investigations. Okay. So this is how you should go, or you should run the path, right? And this is your satisfaction. Okay. And this is why you are a medical graduate. This is why you are a medical graduate, because lots of people are practicing without degree, you know, quacks, right? So what they do, they will advise investigation at the very beginning. You do some CT scan, you do some MRI, you do some pulmonary function test or whatever, okay, and get the diagnosis. This is easy, okay. So no requirement of knowledge here, but your satisfaction is you performed your clinical diagnosis without any much expenses, only with your hands or some tools like stethoscope or like that. Okay. With some tools, you are doing clinical examination of the patient and you are coming to the diagnosis. Okay. And investigation will support your diagnosis. This is your satisfaction as a medical graduate, right? So you need to know how to take history, how to do general physical examination, and how to do systemic examination, right? So general physical examination is done, I guess, right? What are the things? How to check anemia, how to check jaundice, how to check cyanosis, okay, how to check clubbings, how to check edema. These things are already done, right? Okay. So we are going through systemic examination now. Okay. So from systemic examination, you need to know how to examine respiratory system, how to examine cardiovascular system, how to examine abdomen, right? So these are the major system you need to know, and also the examination of nervous system, examination of all the examination of nervous system is huge. Okay, and if you really want to do nervous system examination of a patient, okay, it will surely take your whole day. Okay, because under nervous system you need to check examination of higher function. You need to check examination of all the cranial nerves, starting from olfactory, optic, oculomotor, trochlear, trigeminal, abducens, glossopharyngeal, all 12 cranial nerves you need to examine, right? And you need to test the motor function, and you need to test the sensory function as well. Okay. So examination of nervous system is a broad thing, under which you need to check many things, right? Under which you need to check many things. Okay, examination of all cranial nerves, examination of higher function, examination of sensory system, examination of motor system. All these are under nervous system examination. Okay. So, we are gradually entering into nervous system examination, and right now today we are going to examine the higher function. Okay, higher function. It is a type of function which the primates are not able to do. Okay, the animals, they do not have such complex and developed higher functions. Okay, so what do you mean by higher function? Gross idea. What do you mean by higher function? Any gross idea? Just आपका local language में बता दो. Higher function क्या समझते हो आप? Higher function? Yes, problem solving, definitely. Anything else? We can solve problem. This is our higher function. Okay. Yes. Cognitive function. Cognitive, you have just coined a very important term, cognitive function. Okay. Can you name, what are the indications of doing higher function? किस type का patient देखोगे आप तो higher function करोगे आप, ठीक है? Yes. Yes, reading, understanding, problem solving, everything is under higher function. Okay, everything is under higher function. Correct. You are correct. But you have also termed you have also coined one term, that is cognitive function. Okay, what do you mean by cognitive function? And name a disease where cognitive function is lost. Once you suspect a disease with loss of cognitive function, then only you are going to do higher function. Now, which disease? How to identify? जैसे patient को chest pain हो रहा है, you are going to do cardiovascular system examination. Okay. So, when to do higher function examination? Any case, बता दो. Which case? वार्ड में बहुत सारे patients है, ठीक है? कौन से patient का आप higher function test करोगे? Dementia. Okay, very good. So, is dementia a disease? No. Kind of. No, dementia is not a disease. Dementia is a sign. Okay, dementia is a sign. So, in which disease you see dementia? Alzheimer's disease. Okay, good. Okay. So, you need to know first what is cognitive function and what is dementia. Okay. Cognitive function is higher function that is controlled by your cerebral cortex. Okay. And dementia is definitely a cognitive dysfunction. Okay. Dementia is definitely a cognitive dysfunction where, अच्छा पहले cognitive functions क्या क्या होता है? First of all, cognitive functions क्या क्या होता है? Cognitive functions are, अच्छा yes, memory, yes. Okay. So what is cognitive function? The better is what are cognitive dysfunction, so that you can understand what is cognitive function. So let's ask the question in a different way. Okay. So I am not asking what are cognitive functions, I am asking in a reverse way, what are cognitive dysfunction. Okay. So one cognitive dysfunction is aphasia. What is aphasia? Yes, language problem. Okay. Either a difficulty in understanding words or maybe difficulty in speaking, right? So aphasia, somewhat a language problem. Okay, aphasia. Number 2, apraxia. What is apraxia? Okay, इसका भी बहुत सारे types है apraxia. Just for your idea, I am giving examples. just for your idea, I am giving examples of apraxia. What is apraxia? There are different types of apraxia, right? Constructional apraxia. So, simply inability to perform fine motor activity. Okay, when you are doing any fine motor activity, give an example of fine motor activity. Just buttoning and unbuttoning your shirt. Okay, buttoning and unbuttoning your shirt. This is a fine motor activity, right? So for this, you need muscle coordination, you need proper nerve supply, okay, to do this. But your motor function is okay, your muscles are okay, your nerves are okay. Still, you are unable to do this, okay. So without any motor problem, you have difficulty, or the patient has difficulty in performing fine motor movement. It is called apraxia. ठीक है, पेशेंट बटनिंग अनबटनिंग नहीं कर सकता. इसका क्या रीजन हो सकता है? आइदर देयर में बी पैरालिसिस, फिंगर्स में कुछ पैरालिसिस, या जो फिर मसल्स है यहाँ पर कुछ पैरालिसिस हो सकता है, नर्व इंजरी हो सकता है, लेकिन ये सब नहीं है. ठीक है, पावर टोन सब कुछ मसल में सही है, but still the patient is unable to do fine motor activity like buttoning or unbuttoning a t-shirt or shirt, right? Okay, this is apraxia. Okay, so without any motor, something is happening here, not here in the muscles or fingers, right? So something is happening here, problem is here. Okay, so your cognitive function is controlled by your cerebral hemisphere, the parietal lobe, the temporal lobe, the frontal lobe, the occipital lobe. Okay, so all cognitive functions are controlled by the cerebral cortex. Okay, so problem is here, not in the motor part, right? Not in the peripheral motor part, muscle or nerve, इसमें कोई injury नहीं है. Okay, so apraxia is defined as inability to perform fine motor activity without any sensory or motor problem. Okay. Okay, apraxia, aphasia. Now 3 is agnosia. Okay, so A means inability. Okay, so cognitive functions are fascia, matlab able to understand language and speech. Okay, praxia means ability to perform fine motor activity. Nosia, G-N-O-S-I-A, and nosia means identifying an object. Okay, identifying an object. ठीक है, आपके your eyes are closed. Okay, your eyes are closed, and मैं आपके हाथ में एक पेन दे रहा हूँ, and you feel it. Okay, you feel it, and you can say this is a pen. Okay, you feel it and you can say this is a pen. This is called nosia. Okay, see, nosia. Now the patient is unable to identify. आपके हाथ में एक ब्लॉक दिया गया है, and the patient is unable to identify. क्या है? ठीक है, patient is unable to identify, but there is no sensory problem. हाथ में सेंसेशन का कोई प्रॉब्लम नहीं है, टच, पेन, टेम्परेचर, हाथ में कुछ प्रॉब्लम नहीं है. ठीक है, सो विदाउट एनी सेंसरी प्रॉब्लम, प्रॉब्लम इज हियर. ठीक है, कुछ सेंसरी प्रॉब्लम नहीं है, सेंसेशन में कुछ प्रॉब्लम नहीं है, टच, पेन, प्रेशर, वाइब्रेशन सब कुछ सही है, राइट? सो विदाउट एनी सेंसरी प्रॉब्लम द पेशेंट इज अनेबल टू आइडेंटिफाई एन ऑब्जेक्ट. ओके, with eyes closed, this is nosia. Okay, inability is agnosia. Okay, inability is agnosia. All these are cognitive dysfunction. Aphasia is cognitive dysfunction, apraxia is cognitive dysfunction, and agnosia is cognitive dysfunction. Okay, so aphasia, language and speech problem. Apraxia, inability to perform fine motor activity without any motor problem. Agnosia is inability to identify an object without any sensory problem, right? And number 4 is loss of judgment. Okay, loss of judgment. Okay, aphasia is controlled by your temporal lobe and frontal lobe. temporal lobe and frontal lobe. Apraxia is parietal lobe. Okay. Agnosia, temporal lobe. Judgment, prefrontal cortex. Clear? Inability to tying shoes, yes. Tying shoes, shoeless, buttoning, unbuttoning shirt, okay. Then drawing something, okay. These are all constructional apraxia. Okay. So, dementia. These are all cognitive dysfunction, and you know what cognitive function is: phasia, praxia, gnosia, and judgment. These are cognitive function, and cognitive dysfunction is aphasia, apraxia, agnosia, and loss of judgment. Okay? Okay. Now, you have told Alzheimer's disease. मुझे नहीं पता था. You have told Alzheimer's disease. What happens in Alzheimer's disease? क्या होता है? पुराना चीज भूल जाते हैं. Okay. Have you seen a patient of Alzheimer's disease? At least in movies? Okay. Okay. So, कौन सा memory भूल जाते हैं? Recent past. अच्छा. Okay. Okay, let's see. It is the procedural memory which is not lost. If the patient of Alzheimer's disease was able to drive a car pre-disease, the patient is still able to drive a car. If the patient was a swimmer, the patient is still able to swim. Okay. So, skill, procedural memory, these are not lost. Okay. Anyway, so dementia, what is dementia? Now, next term is to define dementia, because Alzheimer's disease, the major feature in Alzheimer's disease is dementia. Right. Now, you need to define dementia. What is dementia? Yes, loss of cognitive function. Loss of cognitive function, dementia. No. Dementia is memory loss. It must be there. Memory loss plus one or more cognitive dysfunction. Okay. So, dementia is equal to memory loss plus, it may be memory loss plus aphasia, it may be memory loss plus apraxia, it may be memory loss plus aphasia plus loss of judgment. Okay. So, any of these four, any or more of these four. Okay. So, memory loss plus this thing, okay, any. इसमें से 2 हो सकता है, इसमें से 3 हो सकता है, इसमें से 4 हो सकता है, इसमें से 1 भी हो सकता है, right? So, memory loss plus any of these things is equal to dementia. Clear? आपका definition पहले clear करो, तो फिर आप disease को अच्छे से समझोगे. Okay, clear? And Alzheimer's disease is a dementia. I am coming to memory loss because memory এখনো পড়ানো হয়নি, তাই তো? Nervous system এ memory পড়ানো হয়নি তো? There is a big classification in memory. Some memory I will discuss over here also during the examination part. Okay, so examination of higher function. Now I am entering into the higher function examination proper. Until this time it was background knowledge. Okay, until this time it was background knowledge to enter into the higher function. Okay. So, what are the things to check? First of all, you will check the mental state of the patient, level of consciousness, appearance, affect or mood, thought process, perception, insight. You need to check these things. I will come to it. What is insight, what is perception, what is thought. Okay. These are complex things. Next, you will check language and speech. right? The quantity, rate, volume, articulation of words, fluency কতটা ভালো আছে, ঠিক আছে? All these things you will check. And finally the cognitive function. Okay, under cognitive function, see, under cognitive function, orientation in respect to time, place and person. Orientation in respect to time, place or person. आप कहाँ पर हो? मैं हॉस्पिटल में, वार्ड में हूँ. अभी क्या टाइम है? अभी दिन के 10 बजे. ठीक है. ओरिएंटेशन इन रिस्पेक्ट टू टाइम, प्लेस, पर्सन. मैं कौन हूँ? आप डॉक्टर हो. ठीक है. सो ओरिएंटेशन इन टाइम, प्लेस एंड पर्सन इज ओके. ठीक है. सो ओरिएंटेशन इन रिस्पेक्ट टू टाइम, प्लेस एंड पर्सन. अटेंशन टेस्ट करने के लिए बहुत सारा तरीका है. डिजिट स्पैन, ओके, रिमोट और लॉन्ग टर्म मेमोरी टेस्ट करना है, रिसेंट मेमोरी टेस्ट करना है, न्यू लर्निंग एबिलिटी टेस्ट करना है, कैलकुलेटिंग एबिलिटी एंड कॉन्स्ट्रक्शनल एबिलिटी. ओके, सो इतना कुछ अगर हम लोग करते हैं तो ये सब टेस्ट हो जाएगा. वेदर एफाशिया इज देयर और नॉट, एप्रैक्सिया इज देयर और नॉट, एग्नोसिया इज देयर और नॉट, जजमेंट सही है कि नहीं. ठीक है. सो वी नीड टू एग्जामिन in this head mental state examination, language and speech and cognitive function. Okay, although language and speech is one cognitive function, fascia, okay, but we examine it separately because it is a big thing, right? So I'll go through it fast. So see, level of consciousness. Ask yourself, is the patient awake or alert? Does the patient understand your question and respond appropriately and reasonably quickly? अगर ना है तो come to this. Okay. Speak to the patient by name in a loud voice and shake the patient gently like wakening a sleeper. कोई सोया हुआ है उसको जगा रहे हो. ठीक है. Okay. Now, if negative, response is negative, promptly assess the patient for stupor or coma. Okay, severe reduction. Stupor or coma क्या है? Severe reduction in the level of consciousness. Severe reduction in the level of consciousness. Okay. Now patient may be lethargic or upturned, right? Lethargic is drowsy but open their eyes, look at you, respond to questions and then fall asleep again. Right? This is lethargic. Upturned is open their eyes and look at you but respond slowly and are somewhat confused. Right? Now check for appearance, dressing, grooming and personal hygiene. Okay? How is the patient dressed? Is the clothing clean and presentable? Is it appropriate for the patient age and social group? ठीक है. जो ड्रेस है वो अकॉर्डिंग टू सोशल नॉर्म्स ओके है कि नहीं. ठीक है. एंड नोट द ग्रूमिंग ऑफ द पेशेंट्स हेयर्स, नेल्स, टीथ, स्किन एंड इफ प्रेजेंट बियर्ड. ओके, एनी टैटू मार्क्स और लाइक दैट. ठीक है. एवरीथिंग यू नीड टू चेक. सो फिजियोलॉजी ऑफ स्पीच. ओके, क्या होता है? वंस यू लिसन ए साउंड, ओके, यू लिसन ए साउंड, there is a mechanism in your inner ear, okay, organ of Corti. So it takes the signal to the cochlear nerve as action potential. The sound energy is converted into electrical energy, right? So there is a mechanism, and it is also a question for first professional MBBS, how this sound energy is converted into action potential, means electrical energy, right? And it travels through the cochlear nerve and finally to your brain. Right? Okay. So signal is fast received in an area which is called in the temporal lobe Wernicke's area. Yes? Yes. So Wernicke's area, right? In the temporal lobe. Now from Wernicke's area to frontal lobe there is another area, area 41 and 42. What is that? Broca's area in the frontal lobe, right? So receiving area is Wernicke's area where you have comprehension. ठीक है. Where you have comprehension मतलब आप समझते हो कि क्या बोला जा रहा है या फिर the nature of the sound. ठीक है. So Wernicke's area is for your comprehension. and then finally you have the Broca's area in your frontal lobe, which is called the motor area. Wernicke's area is the sensory area and Broca's area is the motor area. Okay. So here is the thing. So you listen over here. This is the Wernicke's area. This is front side. This is back side. Okay. Now here is a fasciculus called arcuate fasciculus. Okay, arcuate fasciculus, and this is Broca's area. This is Wernicke's area. Okay. So Wernicke's area in the temporal lobe, Broca's area in the frontal lobe. Broca's area is area 41, 42. Remember this. Okay. And this is called arcuate fasciculus. Arcuate fasciculus, right? Okay. Now, once you listen a sound or listen a spoken word or sentence, you analyze it with your Wernicke's area. It is the receiving area or the sensory area. Okay. And this signal is sent to Broca's area. Now, Broca's area is responsible for producing speech. ठीक है? तुम कहाँ जा रहे हो? मैं कॉलेज जा रहा हूँ. तुम कहाँ जा रहे हो? So you listen this sentence. तुम कहाँ जा रहे हो? You process it in your Wernicke's area, which is the sensory area, area of comprehension. समझने के लिए area है. ठीक है? Sentence को समझने के लिए जो area है, or the comprehension area is called Wernicke's area. Okay? Have you heard Wernicke's encephalopathy? Those who are alcoholic, Wernicke's encephalopathy occurs. So this area, Wernicke's area is damaged, right? Okay. So from Wernicke's area, signal is sent to Broca's area. Broca's area is in the frontal lobe and it is responsible for motor speech production. Okay? So when the patient is having aphasia, we need to see whether the problem is there in understanding or whether there is a problem in speech producing. Okay? So if there is any problem in the Wernicke's area, तो क्या होगा? My Broca's area is okay. मतलब जहाँ से speech production करना होता है और I say something, that is okay, that machinery is okay. But to understand the spoken words, the Wernicke's area is damaged. So what will happen? It is called sensory aphasia. क्या बोला जा रहा है समझ में नहीं आ रहा है, but I am able to speak. ठीक है? तुम कहाँ जा रहे हो? আমি তো এখন ওই মাঠে গিয়েছিলাম, সেখানে গরু চড়ছিল, আজে বাজে বলছি, ঠিক আছে, এরকম আর কি, ঠিক আছে। ওকে, মানে whatever you are asking a question, ঠিক আছে, the answer is not related to this. He is saying something else. The person is something else, and maybe the patient is coining new words, যে ওয়ার্ড তুমি কখনো শোনোইনি, ঠিক আছে, বা যে ওয়ার্ডের অস্তিত্ব নেই ডিকশনারিতে। The patient is মানে uttering some abnormal words, ঠিক আছে। It is called neologism. Okay, so it is sensory aphasia. Okay, and what is Broca's aphasia? Patient is understanding everything but can't speak. Okay, maybe the patient will be able to write. Okay, so this is Broca's aphasia. Patient can't answer in spoken language. ठीक है, this is Broca's aphasia or motor aphasia. Okay, so major two types you need to know: the sensory aphasia and motor aphasia. Sensory aphasia is also called Wernicke's aphasia. Motor aphasia is also called the Broca's aphasia. Okay, ठीक है, so this is the physiology of aphasia in short. But there are other types of aphasia as well, which is called global aphasia, जिसका Wernicke's area, Broca's area दोनों damage हो चुका है. And there is some conduction aphasia as well. Conduction aphasia is Wernicke's area, Broca's area okay, but the arcuate fasciculus is damaged. Okay, so it may happen in stroke, in alcohol intoxication. ठीक है, stroke में क्या होता है, इंट्रासेरिब्रल हेमरेज हो सकता है या फिर कोई ट्यूमर हो सकता है इंट्रासेरिब्रल. सो डिपेंडिंग ऑन कहाँ पर क्या प्रॉब्लम हो रहा है, द पेशेंट मे बी हैविंग Wernicke's aphasia, Broca's aphasia, global aphasia, conduction aphasia as well. ठीक है, सो इन Wernicke's aphasia where Broca's area is okay, patient is fluent, बहुत कुछ बोले जा रहे हैं, but everything is meaningless. ठीक है? In sensory aphasia, patient is too much talkative, बहुत कुछ बोल रहे हैं, but nothing is related to your question. ठीक है? Nothing is related to your question, and there might be neologism as well. There will be repetitions. Okay? And in Broca's aphasia, patient is understanding everything but unable to speak. There is no fluency. ठीक है? ना you need to treat the patient depend on the severity of stroke or hemorrhage or whatever. Okay, now check the facial expression of the patient, right? Observe the face both sides at rest and during conversation. Watch for changes in expression. Are they appropriate for the topics being discussed? ठीक है, পেশেন্টের সঙ্গে কিছু একটা টপিক নিয়ে ডিসকাস হচ্ছে, সেই টপিক অনুযায়ী ফেসিয়াল এক্সপ্রেশন ঠিক আছে কিনা, ঠিক আছে? কোনো একটা হাসির কথা আসছে, পেশেন্ট কাঁদছে, ঠিক আছে, তো হতে পারে। ওকে, তো ফেসিয়াল এক্সপ্রেশন শুড বি অ্যাকর্ডিং টু দ্য টপিক বিং ডিসকাসড। ওকে, গ্রুমিং অ্যান্ড পার্সোনাল হাইজিন, আচ্ছা এগুলো, এই যে এতগুলো কথা বলছি, এগুলো কেন টেস্ট করবো বা এগুলো কিসে প্রবলেম হতে পারে, কোন ডিজিজে প্রবলেম হতে পারে, সেটা আমাকে জানতে হবে। ওকে, তাহলে গ্রুমিং অ্যান্ড পার্সোনাল হাইজিন ডিটোরিয়েশন, ঠিক আছে, মানে আমার ড্রেসিং সেন্স, পার্সোনাল হাইজিন এগুলো লস্ট হয়ে যাবে কখন? মেবি আই এম ইন ডিপ্রেশন, দ্য পেশেন্ট অফ সিজোফ্রেনিয়া, দ্য পেশেন্ট অফ ডিমেনশিয়া, ঠিক আছে, এই সবগুলোতেই এটা হতে পারে। আই নো ডিপ্রেশন তোমাদের পড়া হয়নি এখনো, সাইকিয়াট্রিতে এগুলো আছে, ঠিক আছে, বাট স্টিল রিমেম্বার ফিউ থিংস, ডিপ্রেশন, সিজোফ্রেনিয়া, রাইট, ডিমেনশিয়া কিছুটা জানা আছে, ঠিক আছে, তো এগুলোতে এটা হতে পারে। এক্সেসিভ ফাস্টিডিয়াসনেস, ঠিক আছে, মানে খুব তাড়াহুড়ো করছে, ঠিক আছে, পেশেন্ট খুব তাড়াহুড়ো করছে, হড়বড় করছে, রাইট, সো ইট মে বি সিন ইন অবসেসিভ কম্পালসিভ ডিসঅর্ডার, ওসিডি। ওসিডি যাদের আছে, ওসিডি জানো তো মোটামুটি কি সিমটমস হয়, ঠিক আছে, আমি আমার রুম থেকে বেরোলাম, লক করে এলাম, থার্ড ফ্লোর থেকে নিচে নামলাম, আমার মনে পড়ছে না লক করেছি কিনা, আমাকে উঠতেই হবে উপরে, ঠিক আছে, আই নিড টু চেক অ্যান্ড পুল দ্য লক অ্যান্ড আই নিড টু বি শিওর দ্যাট ইট ইজ লকড, ঠিক আছে। সো ওসিডি, অবসেসিভ কম্পালসিভ ডিসঅর্ডার, এরকম যাদের থাকে তাদের এক্সেসিভ ফাস্টিডিয়াসনেস, প্রচুর বেশি কথা বলে, ঠিক আছে। আচ্ছা, ওয়ান সাইডেড নেগলেক্ট, লিজন ইন দি অপোজিট প্যারাইটাল কর্টেক্স, ইউজুয়ালি দি নন ডমিনেন্ট সাইড, ঠিক আছে, বডির একদিকের যত্ন নেয়, ঠিক আছে, ওয়ান সাইডেড হেমি নেগলেক্ট, ঠিক আছে, একদিকে নেগলেক্ট করে, এদিকে কি জিনিসপত্র আছে কিছু দেখছে না, এদিকের গুলোই সব দেখছে, ঠিক আছে। Affect. Now, two terms, affect and mood. These are all psychiatry terms. So, psychiatry final year subject. Third year থেকে পড়ানো শুরু হবে. But still, you need to know something right now. ঠিক আছে? For examination of higher function. Okay. So, two major term in psychiatry in the beginning chapter. Okay. Affect and mood. ठीक है? What is the difference between affect and mood? ठीक है? You know basic thing like mania and depression. Depression is low mood, ठीक है, कुछ भी अच्छा नहीं लग रहा है मुझे, बहुत low mood, depression, and mania, I'm enjoying everything, ठीक है, थोड़ा सा ज़्यादा ही enjoy कर रहा हूँ, ठीक है. So there is a spectrum, there is a spectrum. In the negative side you have depression, and in the positive side you have mania, ठीक है, and the normal mental state is in between, zero, not plus, not minus. This is normal mental state. Okay, but some people are having depression, some people are having mania. Okay, okay, so what is affect? Affect is inner emotional state, it is cross sectional at a certain point of time, ठीक है, अभी इस वक्त मेरा mental state कैसा है, ठीक है, this is affect. You know the difference between climate and weather? Okay, so what is climate, what is weather? At a particular point, अभी का जो situation है, this is weather, and climate is long term. Okay, so mood is long term, over a period of time, ठीक है. Affect is inner emotional state, it is cross sectional and appropriateness to the topics being discussed, ठीक আছে, এখনই বোঝা যাচ্ছে. Okay, and mood is over a period of time. Okay, ask the patient, how is your overall mood? The reports from the family and friends may be of value. And has the mood been intense and unchanging or labile? How long did it last? এই সমস্ত কোশ্চেন পেশেন্ট পার্টিকে করা যেতে পারে, নট ডিরেক্টলি টু দি পেশেন্ট। ঠিক আছে, তাহলে অ্যাফেক্ট আর মুডের বেসিক ডিফারেন্সটা হচ্ছে ক্রস সেকশনাল এট এ সার্টেন পয়েন্ট অফ টাইম অ্যান্ড ওভার এ পিরিয়ড অফ টাইম। মানে লাস্ট 6 মাস ধরে মোটামুটি কিরকম, দিস ইজ মুড। ওকে, আজকে এখনই কিরকম, দিস ইজ অ্যাফেক্ট। থট, ওকে, তো থটের আমাদের কি দেখতে হবে, কনস্ট্যান্সি দেখতে হবে, অর্গানাইজেশন দেখতে হবে, কন্টিনিউটি দেখতে হবে। ওকে, আর থট প্রসেস এর কিছু অ্যাবনর্মালিটি, যেমন সার্কামস্ট্যান্সিয়ালিটি, ঠিক আছে, কাম ব্যাক টু দ্য টপিক বাট ডেভিয়েটস অফেন। ওকে, মানে কিছু একটা টপিক নিয়ে ডিসকাস করছি, ডেভিয়েট করে যাচ্ছে, পেশেন্ট ডেভিয়েট করে যাচ্ছে, ওই টপিকটা বলতে চাইছে না, মাঝে মাঝে ফিরে আসছে। ঠিক আছে, আর ট্যানজেন্সিয়ালিটি হচ্ছে ডিরেলমেন্ট ফ্রম দ্য টপিক, সেই টপিকের চারদিক দিয়ে ঘুরছে কিন্তু টপিকের মধ্যে আসছে না। ঠিক আছে, সেই টপিকের চারদিক দিয়ে ঘুরছে কিন্তু মানে এক্স্যাক্টলি ইয়েতে আসছে না। আর ফ্লাইট অফ আইডিয়াস হচ্ছে মানে অ্যাব্রাপ্ট, ফটাফট টপিক চেঞ্জ হয়ে যাচ্ছে। ওকে, ফটাফট টপিক চেঞ্জ হয়ে যাচ্ছে। এগুলো খুব ডিটেলসে যাচ্ছি না, কারণ সাইকিয়াট্রিতে আছে, খুব ডিটেলস আমাদের লাগবে না। ঠিক আছে, জাস্ট কিছুটা বলতে পারলেই হবে। নিওলজিজম, কয়েনিং নিউ ওয়ার্ডস, যেটা বললাম। ঠিক আছে, ওকে, তো পেশেন্ট একটা অ্যাবনর্মাল কিছু একটা ওয়ার্ড বললো, মানে যেটার কোনো মানে নেই আর কি। ওকে, incoherent, speech is incomprehensible, illogical, with lack of meaningful connection. Confabulation মানে fabrication of fact। ঠিক আছে, মানে কিছু একটা ঘটনা ঘটেছে কিন্তু সেটা কেন ঘটেছে একদম অন্যরকম বলছে। ঠিক আছে, এক্সাক্ট কারণটা বলছেন। Seen in alcoholism, echolalia is repetition of words and phrases of others. All these things are seen in schizophrenia. Neologism তো ইয়েতেও হয়, ব্রোকাজ অ্যাফাসিয়াতেও হয়, রাইট, ওয়ার্নিক্স অ্যাফাসিয়াতে হয়। থট কন্টেন্ট, ওকে, এখানে কতগুলো জিনিস জানতে হবে। হোয়াট ইজ অবসেশন, হোয়াট ইজ কম্পালশন, হোয়াট ইজ ফোবিয়া, হোয়াট ইজ অ্যাংজাইটি অ্যান্ড হোয়াট ইজ ডিলিউশন। ওকে, ডিলিউশন, আর তারপরে আছে হ্যালুসিনেশন, ইলিউশন আর হ্যালুসিনেশন। ঠিক আছে, মেন এই তিনটে খুব ভালো করে জানতে হবে। ডিলিউশন, ডিলিউশন হচ্ছে ফিক্সড ফলস বিলিফ। ঠিক আছে, আমার মাথার মধ্যে একটা ফিক্সড ফলস বিলিফ হয়ে আছে যে শি ওয়ান্টস টু কিল মি। ঠিক আছে, নাও নোবডি ক্যান চেঞ্জ ইট। ওকে, নোবডি ক্যান চেঞ্জ ইট, এটা আমার একদম দৃঢ় বিশ্বাস। ওকে, ফিক্সড ফলস বিলিফ। ওকে, ডিলিউশন, ফিক্সড ফলস বিলিফ। ইলিউশন, ওকে, মিসইন্টারপ্রিটেশন অফ রিয়েল এক্সটার্নাল স্টিমুলি, মিসইন্টারপ্রিটেশন অফ রিয়েল এক্সটার্নাল স্টিমুলি, যেটা সত্যি করে আছে। ঠিক আছে, রিয়েল এক্সটার্নাল স্টিমুলি, যেমন একটা রোপ পড়ে আছে, আমি ওটাকে ভাবছি স্নেক। ঠিক আছে, অথবা মিস্টেকিং রাসলিং লিভস, পাতা, শুকনো পাতা খড়খড় করে আওয়াজ হচ্ছে, সেটাকে আমি ভাবছি যে কেউ কথা বলছে। ঠিক আছে, সো দেয়ার ইজ অ্যান এক্সটার্নাল স্টিমুলাস, রোপটা আছে বা পাতাগুলো আছে, দেয়ার ইজ অ্যান এক্সটার্নাল স্টিমুলাস দ্যাট এক্সিস্ট, রাইট, সেটাকে আমি অন্য কিছু ভাবছি, দিস ইজ ইলিউশন। অ্যান্ড হোয়াট ইজ হ্যালুসিনেশন, পারসেপশন উইদাউট এক্সটার্নাল স্টিমুলেশন। ঠিক আছে, আমার কানের পাশে কোনো কথা হচ্ছে না কিন্তু আমি কিছু শুনতে পাচ্ছি, কেউ বলছে। ঠিক আছে, বা কাউকে দেখতে পাচ্ছি, ভিজুয়াল হ্যালুসিনেশন। অডিটরি হ্যালুসিনেশন, আমি কিছু শুনতে পাচ্ছি কিন্তু এক্স্যাক্টলি কোনো সাউন্ড নেই চারিদিকে। ঠিক আছে, আমি কিছু শুনতে পাচ্ছি, কেউ ডিসকাস করছে। ঠিক আছে, হ্যালুসিনেশন, কাউকে দেখতে পাচ্ছি সামনে। ঠিক আছে, কাউকে দেখতে পাচ্ছি সামনে, রাইট, ওকে, কিন্তু কেউ নেই সামনে, কেউ নেই। ওকে, দিস ইজ হ্যালুসিনেশন। ওকে, both are seen in schizophrenia, delirium, PTSD. What is PTSD? Post traumatic stress disorder. Okay, post traumatic stress disorder, কারোর near and dear ones কেউ মারা গেছে, ওকে, lost someone, ওকে, সো পোস্ট ট্রমাটিক স্ট্রেস, সেখানে এই ধরনের ঘটনা ঘটতে পারে। ঠিক আছে, হ্যালুসিনেশন, অডিটরি ভিজুয়াল হ্যালুসিনেশন খুব কমন। ইন schizophrenia it is a hallmark feature. Insight, insight means do I know that मुझे ये प्रॉब्लम है। ठीक है, insight means कि पेशेंट को पता है कि नहीं कि मुझे ये प्रॉब्लम है। ठीक है, आई एम सिजोफ्रेनिक, मुझे पता है आई एम सिजोफ्रेनिक। ठीक है, So it is a spectrum. The patient can be completely denial. ठीक है, मुझे कुछ नहीं है, पेशेंट पूरा डिनाई कर रहा है, ठीक है, आई डोंट हैव एनीथिंग, कंप्लीट डिनायल, एंड ऑन द अदर साइड नॉलेज ऑफ इलनेस, यस मुझे पता है आई एम सिजोफ्रेनिक, ठीक है. So this is the thing, okay. So you need to check the insight as well, whether the patient is aware of his illness or not, or there is complete denial, okay. Okay, लैंग्वेज एंड स्पीच में क्या क्या देखना है, टॉकेटिव और साइलेंट, ठीक है, स्पॉन्टेनियस और लिमिटेड टू डायरेक्ट क्वेश्चन, रेट देखना है, फास्ट स्लो देखना है, वॉल्यूम देखना है, सॉफ्ट और लाउड, आर्टिकुलेशन ऑफ वर्ड, देन फ्लुएंसी देखना है. फ्लुएंसी वेरी इंपॉर्टेंट टू डिफरेंशिएट बिटवीन वार्निक्स एफेसिया एंड ब्रोकास एफेसिया, राइट. हेजिटेशन है कि नहीं, हेजिटेंसीज है कि नहीं, गैप्स है कि नहीं, मोनोटोनस है कि नहीं, सर्कमलोक्यूलेशन, ठीक है, अगेन सराउंडिंग द टॉपिक, राइट. ओके, so circumlocution, what you write with, okay, malformed what, I write with a den, it is called paraphasias, okay. I write instead of pen, patient is telling den, okay. I write with a abnormally unnatural word, or almost there is no existence of the word, right. I write with a bar, okay. So the patient is telling another word instead of pen, okay, wrong. स्लो स्पीच डिप्रेशन में होता है, एक्सेलरेटेड लाउडेड स्पीच इन मैनिया, राइट. डिसआर्चिया, डिफेक्टिव आर्टिकुलेशन, डिस्फोनिया, impaired volume, quality or pitch of the voice, aphasia, disorder of the language, that has already been discussed. Disorder of the language without any motor, visual, auditory or learning problem. Problem is here in the cerebral cortex, right. Okay, a person who can write a correct sentence does not have aphasia, ठीक है. अच्छा, एगुलो शब्द देखते हैं, वर्ड कॉम्प्रिहेंशन, रिपीटेशन, नेमिंग, रीडिंग एंड राइटिंग, एवरीथिंग शुड बी चेक्ड. एंड हियर इज ए this chart is directly picked up from textbook of Harrison, you know Harrison, medicine textbook, okay. But what you need to know, major difference between Wernicke's area and Broca. There are different types of aphasia. Everything is not required for your level. At least try to remember Wernicke's aphasia and Broca's aphasia. Okay. At least try to remember first two things, Wernicke's aphasia and Broca's aphasia. So comprehension, Wernicke's aphasia में impaired हो जाएगा, ठीक है, because Wernicke's aphasia, Wernicke's area is the comprehension area, समझने के लिए area है, right? So comprehension impaired in Wernicke's aphasia, repetition impaired, naming impaired, fluency preserved, okay, fluency preserved, okay. In Broca's area, preserved is comprehension, Broca's aphasia मतलब मोटर में प्रॉब्लम है, लेकिन समझ रहे हो आप अच्छी तरह से. So comprehension is preserved, okay. Repetition impaired, naming impaired, fluency decreased, right. Neologism किसमें होता है, neologism Wernicke's aphasia में होता है, ठीक है. At least try to remember the difference between Wernicke's area and Broca's area. It is also a very frequent question for you. Difference between Wernicke's area and Broca's area, very frequent. It comes in your professional MBBS examination. Difference between Wernicke's aphasia and Broca's aphasia. Okay. Orientation in respect to time, place, person. Okay, you need to check orientation in respect to time, place and person. So attention के लिए बहुत सारे टेस्ट है, but I'd like to emphasize on number 2, serial 7s and spelling backwards test. Okay, attention, patient के attention check करने के लिए. Okay, if the patient is educated, then serial 7s, very frequently we do this, serial 7s and spelling backwards. ठीक है, world, WORLD. Okay, so DL in this way, backward, spell backward. And serial 7s, serial 7 subtraction. So take 100, then 93. Okay, 7 subtraction करते करते, ठीक है, समझ में आ गया. 100, 93, then 86, 79, 72. In this way आपको डाउन होना है, ठीक है. So this is the way to check the attention of the patient. अच्छा, poor performance while checking attention, poor performance कौन से disease में हो सकता है? Delirium, late stage of dementia, intellectual disability, anxiety, depression and low education level as well. ठीक है? Memory. Okay, for memory, these are the protocol how to ask the patient. ठीक है? So remote memory जब आपको पूछना है patient को, actually थोड़ा सा physiology of memory बता देते हैं. ठीक है? So when one thing is immediate memory, then recent memory and then long term memory. ठीक है? So we can compare it with a computer hardware. Okay. So we have not RAM, random access memory, we have RAS, reticular activating system. Okay. We have reticular activating system. These are all under central nervous system. अभी तक नहीं हुआ सेंट्रल नर्वस सिस्टम आपका, इसलिए थोड़ा सा प्रॉब्लम होगा. बट रिमेंबर देयर इज रेटिकुलर एक्टिवेटिंग सिस्टम, ओके, इन द नर्वस सिस्टम, रेटिकुलर एक्टिवेटिंग सिस्टम, रैस. सो रैस इज फॉर इमीडिएट मेमोरी. ठीक है? सो आई टेल यू माय फोन नंबर इज 9609206586. टेल मी. ठीक है? सो दिस इज इमीडिएट मेमोरी. ओके, मैंने बोला इसको, मेरा नंबर बोला एंड यू रिपीट immediate memory. So she will retrieve from RAM, random access memory. Okay, and in ours it is RAS. Okay, reticular activating system. Okay, now again I'm telling my number 9609 this blah blah blah, and you tell me my phone number day after tomorrow. Okay, so she will retrieve. So first if I ask her immediately, she will retrieve from RAS, random access memory, right, reticular activating system. If I ask her after 2 days, okay, day after tomorrow, right, then she will retrieve it from hippocampus. So hippocampus is the gateway of memory. First you register it in your RAS, reticular activating system. First register point is reticular activating system. Then you send this information to hippocampus in the temporal lobe. Okay, send this information to hippocampus, and once you give priority to this information, okay, once you give priority to this information, then she will send this information to neocortex for long term memory. ठीक है? ओके, सो मैंने अपना फोन नंबर बताया, राइट, रिपीट, इट इज इमीडिएट मेमोरी. डे आफ्टर टुमारो, रिसेंट मेमोरी. नाउ इट इज इन द हिप्पोकैम्पस. Now after 1 month, if I ask her what is my phone number, वो हिप्पोकैम्पस से गायब हो गया. ठीक है? अरे सर का नंबर याद रख के क्या करेंगे? ठीक है, भाग. ओके, बट शी विल रिमेंबर few very important things that will be registered to neocortex for long term memory, like her birthday. Okay, the first day she met her BF may be important. Marriage anniversary, right? So these things are important. She will give priority and she will send to neocortex, right? Okay. So immediate memory you retrieve from কোথা থেকে রিকল করে immediate memory নিয়ে আসা হয়? RAS, reticular activating system. Recent memory কোথা থেকে retrieve করা হয়? Hippocampus. Long term memory কোথা থেকে retrieve করা হয়? Neocortex. Very important MCQ for NEET PG. ठीक है? Every alternate year it comes. Okay. Now you will check remote memory, you will check recent memory, events of the day. For remote memory we can ask birthday, anniversaries, name of the school attended, jobs held, right? These are the things you can ask. Now new learning ability. Okay, so there are some protocols. Give the patient 3 or 4 words like table, flower, green, hamburger, and ask the patient to repeat them so that you know the information has been heard and registered. Okay, new learning ability. Remote memory impaired in late stage of dementia. Recent memory is impaired in dementia and delirium, and amnestic disorder impair new learning ability. Okay, amnestic disorder impair new learning ability. जब मेमोरी का थ्योरी क्लास होगा तो और डिटेल में इसको डिस्कस करेंगे. Now dementia and delirium, this difference is important. This is a question for you as well as this is very important question in psychiatry, in medicine as well. Okay, so what is the difference between, at least for your level, you remember few points how to differentiate between dementia and delirium. Okay, remember delirium is temporary, right, and dementia is progressive. Okay, so Alzheimer's disease is a dementia, but alcohol intoxication is delirium. Okay, okay, so age is a risk factor for dementia, definitely. Okay, it is affected by aging but lower than dementia. Okay, in most cases it's irreversible. Dementia is irreversible. I told it is long term, it is progressive, it is irreversible, it cannot be reverted back to normal. Okay, but it is reversible when fully treated. When fully treated, some intoxication like alcohol or any substance, okay, alcohol, cannabis, okay, marijuana, right? So these things are reversible. Delirium is reversible. Delirium is also cognitive dysfunction. It is also cognitive dysfunction. Okay, cognitive dysfunction with memory loss. It is also cognitive dysfunction and memory loss. But how to differentiate between dementia and delirium? Dementia is slowly progressing and it is irreversible. आपको इसको normal नहीं कर सकते आप, ठीक है? But delirium is mostly due to substances. Okay, alcohol, ganja, whatever. Okay, so delirium is mostly due to substances, and when the patient is treated, it is revert back to normal. Okay. Okay, now check finally calculating ability. Easy. Poor performance suggests dementia or aphasia, but should be measured against the patient fund of knowledge and education. ठीक है, तो पेशेंट का एजुकेशनल बैकग्राउंड भी आपको लेना है, ठीक है, उसके अकॉर्डिंग आप पूछो, ठीक है. सो से फॉर एग्जांपल कोई पेशेंट है जो 10th तक पढ़ा है और आप उसको कैलकुलस या डेरिवेटिव पूछ रहे हो, तो नॉट पॉसिबल. ठीक है. कंस्ट्रक्शनल एबिलिटी. ओके, सो आपको ड्रॉ करना होगा एक घड़ी ऐसे एंड आस्क द पेशेंट टू ड्रॉ इट. ठीक है, एंड द इंटरप्रिटेशन पुअर, फेयर एंड गुड. So with intact vision and motor ability, poor constructional ability suggests dementia or parietal lobe damage. Okay, I told you, see, apraxia is parietal lobe. It is constructional apraxia. Okay, constructional apraxia. See, apraxia is seen in parietal lobe dysfunction. Okay, parietal lobe damage. So constructional ability. It is constructional apraxia. The patient is unable to draw the clock. Okay, here is the patient drawing, and here is your drawing. Okay. So it is constructional apraxia. Okay, it is a bedside tool, mini mental stress examination, mini mental state examination. So it is a bedside and developed by Falstein, and the components are orientation, registration, attention, recall and language. ये 5 points देखा जाता है, total points 30, and significant cognitive dysfunction when it is less than 24. Okay, you don't need to perform this thing, just for your knowledge. It is a bedside tool because higher function examination is a long thing. Okay, higher function examination, it takes time because you need to interact with the patient for some time. Okay, so it is a bedside tool. Very quickly you check a few things and come to the conclusion whether there is having cognitive dysfunction or not. Okay. Another thing I didn't discuss, that is loss of judgment, prefrontal cortex. Okay. Prefrontal cortex is for judgment, your social judgment, कि कब क्या करना है, कब क्या चीज बोलना है. Okay, this is your judgment. Okay, कौन सा ड्रेस कब पहनना है, तो this is your judgment. So you are wearing your lab coat over here. Okay, so you are not in casual. So this is your judgment. Okay, this is your judgment, right? So it is controlled by. You have seen, we have checked during higher function examination the dressing sense and all these things. These are all judgment of the patient. Okay, actually we are checking the prefrontal cortex, right, for the judgment. Okay, and something is also there which is called ideomotor thing. It is also controlled by your parietal lobe. So the thing is, you give the patient a matches and a candle. Okay, and ask the patient to lit it up. Okay, so patient को क्या करना होगा, पहले माचिस से स्टिक निकालना होगा, फिर उसको रब करना होगा. ठीक है, so there is a sequence of events and the patient cannot make the sequence of ideas. It is also controlled by somewhat prefrontal cortex and some parietal lobe activity. Okay, it is called ideomotor activity. So the idea will come to your mind कि पहले मुझे matches लेना है, एक stick निकालना है, फिर उसको lit करना है, फिर candle को lit करना है, ठीक है? So there is a sequence of movement, sequence of fine motor movement. So this idea is not coming to the patient, ठीक है? Okay, so majorly you have apraxia. What you need to test? You need to test aphasia, apraxia, agnosia, and loss of judgment. Okay, by interacting with the patient and giving some question to the patient and simply by observing the patient. Okay, okay. So this is overall examination of higher function. Okay, for your theory question, aphasia is very important. So study detail in aphasia. Aphasia is a theory topic, and also difference between Broca's aphasia and Wernicke's aphasia. The question may also come as what is the difference between sensory aphasia and motor aphasia. Wernicke's aphasia is sensory aphasia, Broca's aphasia is motor aphasia. Okay.